This is Dr. Bobby Parmar,
This is Dr. Paul Maximus.
and we're getting into the pre-IV iron in pregnancy video. Let's dive straight in. So first off, we're assuming that you watched the video, FAQ video for everybody. Watch that first if you haven't already, and then circle back to this. First question, can I get one?
Yes, you absolutely can. There are a couple conditions. One of them is if you have a ferritin, which is your blood iron storage level, normally tested under 50 to qualify, and that it has to be within the last 3 months. As a pregnant person, we don't have any data on safety in the first trimester, so we err on the side of caution, and you need to be in the second or third trimester. And you can get it all the way up until the date of your delivery.
Next question, how much do I need? Pregnancy is iron expensive. You'll see in the first trimester here that there's about 3 hamburgers per week that goes towards building a baby. And then there's 7 to 10 hamburgers per week in the second trimester. And then that goes up to 25 hamburgers per week at the peak of the third trimester. That's monstrous. Then when you get to delivery, vaginal birth takes another 125 hamburgers and C-section takes 250 hamburgers. So overall, when you do the full calculation, a woman's body is made up of about 3,000 milligrams of iron, that's 1,500 hamburgers, and a baby, all told, from conception to delivery, is about 500 hamburgers, plus or minus the vaginal versus C-section outcome. But that's pretty expensive. That's about 33% of your total body amount of iron. So based on the first video that you saw, you know that we dose iron infusions based on your ferritin. So the higher your ferritin is, the less you need, the lower it is, the more you need. However, in that first video, we were talking about non-pregnant patients. Here we're talking about pregnant patients. You know a baby is about 1,000 milligrams of iron or 500 hamburgers of iron. So the majority of pregnant patients watching this, whether second or third trimester, you're qualifying for 1,000 milligrams of iron infusion. Next question. We get this all the time. Can't this be done under MSP?
It can, except for it's not often offered. You usually need to be anemic in order for you to qualify under the public healthcare system. Anemia is different at different stages of your pregnancy. Your hemoglobin needs to be below 105 in the second try and needs to be below 110 in the third trimester. Don't ask why, it's kind of complicated. And you need to have not been able to successfully take oral iron for at least a month. That can be particularly strict on a lot of people who, especially in pregnancy, get side effects from oral iron, can't tolerate it. You can get constipated from it and add to the nausea that might already exist. Outside of that, you don't really have any other qualification that can get you into the MSP-based system because they don't use low iron as the qualifier. It's low hemoglobin and low iron.
Low ferritin.
Yeah. We don't think, and we at Gravity don't use the same threshold. We think iron deficiency is very important to treat, and so we have a little bit more of an inclusive way of looking at this, and so your ferritin just needs to be below 50 in the last 3 months, like we said before. And on top of that, the wait list for the MSP system, if you do qualify even, is really long. We know that it can be months before you actually get an infusion, sometimes even being past your due date.
All the while you're exhausted, and as we'll see in a moment, your baby's not having as fun of a time or as easy of a time in development.
This is another way of looking at how often people are anemic in pregnancy. Those are the levels I just described, and how often people are iron deficient in pregnancy. You can see there's a big difference, that if we're a little bit more inclusive, which at Gravity Health we very much are, then we are treating many more people and then preventing a lot of negative outcomes by treating them.
So you can see the vast majority of women having a ferritin less than 50 would be qualifying for an iron infusion on the basis of iron deficiency, not needing to wait for iron deficiency anemia to be the case, which is the most severe end of the spectrum. So now, how will my baby benefit?
Babies benefit in a lot of ways. We don't have a lot of long-term data on this, but the data that we do have is that the more iron a woman has in her pregnancy, the more iron baby gets when baby's born, which then translates into future health concerns that they're more at risk for, including cognitive concerns. They're more likely to be weirdly clumsy, and we think that has to do with oxygenation, less activity, less sociable in the sense that there's more attachment, there's a lot more hesitancy to be sociable, They're more likely to be less consolable and unhappy generally. They're not depressed babies, but they're just less happy related to other babies given enough iron at the time of their birth. And they tend to be, and this is the most obvious one, less alert, have less good quality sleep, and therefore have less energy. And these are a lot of future consequences that we try to prevent because we don't know whether or not after 5 years, 10 years, this is compounded on. So we'd like to be able to avoid soon as possible.
There's some really interesting studies on this too, not to scare anybody, but there's data showing even 10 years after birth, the consequences of low iron, and that they're eye-opening to see. So you'll see a lot more of those on our website, www.ironrxuniverse.com. Poke around there, you'll be able to read for days. But very important to fix iron deficiency, not just for your sake, but for baby's sake, and not just for the immediate term, but for the long term. So the next question we get is about safety and side effects. You know from watching the first video that safety is very good for the iron infusion options that we use. There are two options we'll get to in a second, but side effects effectively for both are the same. They're very low. There's about a 5% chance of having a mild flushing or some nausea in the first couple of minutes of the IV. That's regardless of the iron infusion that's administered, the formulation administered. These 5% chance of mild infusion reactions pass quickly on their own. They're inconsequential. Of course, we're going to be with you and we'll be monitoring and looking after you. And so you'll let us know if you feel anything unusual. But in vast majority of cases, it's a poke on the arm. You lay back in a comfortable chair, bring a friend, bring a laptop, bring a phone, or just take a nap. We have super comfortable chairs. That's limiting, and the benefits far outweigh any risks. There are two iron infusion formulations that we use, monoferric and venifer. I'm going to let Bobby sort of take you through the difference between them.
The difference is mostly in convenience and cost. The one that we use now is called monoferric. We've been using it for a long time in non-pregnant people, but as of 2025, it's now approved for pregnancy. Venifer has been what's called the legacy product that's been used predominantly before, except that there's big differences between them, which is why we're so happy that monoferric has now been given the stamp of approval. And it's one in the time. Venifer usually needs 3 or 4 infusions because the amount that you can give somebody in a single dose is a lot lower. It's about 30% of the total amount that you can get with monoferric. And it costs more. And each time you add up not just the cost of the medication, especially if your drug coverage covers a percentage of it and not the entire amount, it's also the cost of getting an infusion. Usually if you're going to a private clinic like ours, we charge for the time of the infusion. Then the time it takes you to get there, the parking, and then if you have other children or work, taking time off work, and then getting childcare. It adds up, and a study has even shown that this is a reason why a lot of women don't get their second, third, and fourth infusions in pregnancy, because all of these things are just nuisances and make it inconvenient. Whereas monoferric, normally the drug is covered by a drug plan if you have one. If you're getting 80% coverage or to 100% coverage, that's usual. And that the amount of time to get it is way less. You only need 1 infusion, and it's a lot shorter in the duration of the infusion itself. It makes a lot more sense for both cost and time, never mind convenience, to choose monoferric because they're equally as safe.
Great. Oh yeah, so you're basically saving $700 and 7 hours difference between the two. So if you're watching this and you're booking in at another clinic, let's say, or you're considering multiple clinic options, great, go anywhere. But if they offer you Venifer as the only choice, consider a different clinic because they're at least 5 years behind with some of the options that are available. Monoferric's been around in Canada, been approved since, I think it was at least 2018. And it was largely used in non-pregnant populations, and the data is just accumulated enough that now we're like, okay, why are we still doing Venifer in pregnant populations? Monoferric is phenomenal.
And it's been
safe,
used
effective.
in other countries for that entire time and used safely with pregnancy in other countries. So Canada's finally caught up.
Finally caught up. So don't get Venifer if you have the choice. Monoferric, one and done. Save yourself hundreds of dollars and several hours.
We can't wait to see what you do with all that iron for you and baby.
See you at Gravity Health.
Come on in. See you soon.
Bye.